Thank you very much. You always make it look so easy and create some controversy. Just when I think the surgeons and cardiologists get along, we now have surgeon's view versus cardiologist view?
Yeah.
Okay,
I guess
fantastic.
that's the term I use. So.
Yeah, all right, fantastic. I'll give you full credit and send them your way. So our next speaker is Dr. João Cavalcante, who's been a brilliant addition to our practice in Minneapolis, and he's going to be speaking on the essential roles for CT and MRI. João?
Thank you very much, Paul, for the kind introduction. Ladies and gentlemen, it's a pleasure and honor to be here at CVI 2019, and congratulations for such a great summer event. Look forward to meeting and interact with lots of you. And my role that was assigned here was to talk about the role that CT and MRI has into the understanding of tricuspid regurgitation and the timing of the therapy, trying to combine both of what Dr. Serrano mentioned as well as Dr. Han just mentioned. Those are my updated relevant disclosures. I had a couple of slides borrowed from Paul, and I think this is an important one. I think we have to say a little bit of mea culpa in terms of the potential reasons that we have been calling the tricuspid valve, or tricuspid regurgitation for that matter, the forgotten valve. It's relatively an understudied area until the very recent time, in the last 5 years. There's this very long indolent period in which severe TR perpetuates and not develop the lack of development of right heart failure symptoms. There is a consistent undercoding of TR severity, and this is in large part due to the reliance on the collar Doppler with a very, very big capacitance of the right atrium. And infrequently, we underestimate as well the size of the right ventricle and systolic function. And many issues also related to the preload sensitivity of the right ventricle and the tricuspid regurgitation, which is quite dynamic and changes with diuresis. Not to belate into also the fact that the right ventricle is quite a difficult timbre to be imaged with a two-dimensional echo. If you take the left ventricle as the bagel and the croissant-shaped right ventricle, depending on how the probangulation is, let me actually change this here for, I think, there you go. Depending on how the probangulation goes, a slight rotation might give a normal right ventricle to the right ventricle that might be slightly dilated. And then how are we going to be able to rely on this quantification moving forward? And therefore, many parameters have been proposed to evaluate for that. In terms of tricuspid regurgitation grading, there has been a lot of developments in terms of expanding this grading from torrential to massive TR, and several parameters have been outlined here by both Dr. Han as well as the updated guidelines in terms of quantifying that. So it shouldn't be so hard if you have those three patients on the left here, patient with trace mild, patients on moderate regurgitation, and patients on the far right with massive torrential TR. So it shouldn't be so hard, but let's take a look at this patient with moderate TR. So we do have several other views as recommended by the guidelines. We have the dedicated RV, we have the RV inflow view, and I apologize for the lack of playing here. But as you can see in several of these views, as well as the hepatic veins, that this patient, despite our best attempt, we could not find a flow conversion zone. This is a TR jet. We see the right atrial size. We see systolic flow reversal in the hepatic veins, particularly after the pacemaker. So this patient is intermittently paced, and the desynchrony induces that, and this plethoric IVC. So when we take a look into the updated guidelines, this patient would have criteria that would meet from mild, from moderate to severe. So the question is that what does he have in terms of quantification here? There is a multitude of things and there is no hierarchy. The same patient, same day, just switching probes from a 3D TTE, highlighting the importance of understanding that. No changes in Colligan Nyquist. Now we have a patient that has much more TR, and when we're looking at this by 3D vena contract, we can have anywhere between 0.5 to 0.86, and therefore severe TR was consistent with that. And this perhaps might be an attempt with the new proposed scheme by Dr. Han and Dr. Zamorano to quantifying this with 3D vena contractor. But we do not integrate into yet what is the consequence of the downstream consequence of the TR, which is actually the right ventricular remodeling and function and the pulmonary pressures, which needs to be interpolated. This is a paper that came out from Minneapolis Heart Institute by Dr. Nemoto, Paul Saraja, Robert Schwartz, showing that as TR severity increases, there is a consequential increase in the tricuspid annulus. And this is despite indexing for the body surface area. And there is a very good correlation of dilation of the right atrium and tricuspid annular dilation. So one of the first chambers, the cannery in the cold mine, would be actually the right atrial size that continues to dilate and then stretches the annulus. This is another slide from Paul that I also adapted that looks into the potential construct for the tricuspid regurgitation natural history. This moderate tricuspid regurgitation, which we call moderate, might actually be a little bit worse. There's an impairment already for these patients with the consequential right atrial dilation, tricuspid annual dilation that begets more TR. This years of indolence, the right atrium that becomes down the bag chamber to adapt to that, the circularization of the tricuspid annulus, which has been shown. Then you have consequential left and right atrial dilation, atrial fibrillation that begets more TR, and then eventually right ventricular dilation, right ventricular failure, which is a late phenomenon, and then right heart dysfunction with massive to torrential TR, and then kidney dysfunction and liver dysfunction, which ultimately also increase this patient risk. If you wanted to take just one single idea for this, just think about the ice cone. This illustrates that the first chamber that dilates is the right atrium, then tricuspid annulus. By the time it reaches the right ventricle dilation, this is end story, and some of these ventricles might not be recoverable. Now, how can we integrate this into CT and MRI? So in MRI, we can do this without the need of contrast. This is a paper that we have participated with Becky as well recently, highlighting the importance to quantify volumes, function, as well as tricuspid regurgitation. We do not need to use contrast. We can do this with three-dimensional and quantify end systolic and diastolic and stroke volume. In this case here, the patient had a forward stroke volume of potentially 101, but when we measure the flow that left the pulmonary artery, only 46 was left. Therefore, the regurgitant volume that went back into the right atrium was 55 mLs, and when you divide that 55 by 101, you have a tricuspid regurgitant fraction of 54%, which indicates severe TR. We do not need contrast for that. We can also image patients with devices, patients with ICD or patients with pacemaker, despite not being even MRI conditional. It creates some artifact, but we still can measure reliably that. Patients that have had prior implants of mitral clip, tricuspid clip, become much more challenging. As you can see here, there's significant dephasing created by the material prosthesis of the mitral clip that pretends very difficult analysis of this right ventricle, and therefore perhaps we need to borrow into CT to understand that. The technology of MRI is also evolving. In our center now we have the sequence available, which is a free breathing real time. Patients with atrial fibrillation, right heart failure, frequently have pleural effusions. They cannot do breath holds. This is the same patient, same scanner, but just different sequences, a non-diagnostic to a truly diagnostic scanner. So technology continues to evolve and need to be updated. And this might be important because more important than perhaps tricuspid regurgitation might be the suffering of the right ventricle with the decrease in ejection fraction and right ventricular remodeling. With CMR, we can also look with late gadolinium enhancement imaging fibrosis, which has been associated obviously with other diseases, but also with lack of recovery of ejection fraction. Now switching gears to CT. So for CT, this has been a very important player into not only as we learn from TAVR, but also for right side of valve lesions, quite important. It's important to understand also technological developments that it is important as it is to scan the whole heart with one heartbeat, and you would be able to do this with a higher number of detectors. It's important to have adequate temporal resolution, which is the click, 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 click. You need to have a very fast shutter speed to freeze motion. There are specific protocols that we have for enhancement of the right-sided chambers, in particular for tricuspid patients. This is a case from our center, a patient with atrial fibrillation, rapid ventricular response, which is a common phenomenon. We tend to inject about 60 to 100 cc's of contrast, usually between 3 and 4 cc's per hour, and we track this either in the left atrium or in the descending aorta as soon as we see that. Majority of these patients also would have renal impairment, and so a preferential enhancement of only the right ventricle would be required, and would decrease, obviously, the amount of contrast. After you have done this properly, then you can see images such as this one, that we can see a very right-dilated chamber, right atrium, right ventricular chamber, and not enough enhancement of the left ventricle in this patient with had advanced GFR. But we're still able to quantitate this reliably through the cardiac cycle. This is an anatomical analysis for the tricuspid annulus height, the anatomical regurgitant orifice area, which is different from the effective regurgitant orifice area. We can track this in average throughout the systolic frames. And the other thing that also we have been learning with this software is this endoluminal view. So this is the capability of being able to see the leaflets for the first time if you do the proper timing of this. And this is, as I would argue, that would be quite difficult on the surgical view here to be able to see this reliably with other methods. And to calculate, for example, use PISA, this is not a hemisphere by any stretch of imagination. And therefore, this is where it really lacks the validation and the capability to discern who is going to respond or not. This is another example of a patient with a large MI. You see that there is a significant infarct here and lack of coaptation, tethering the posterior angle. We can use the CT as well for planning the tricuspid procedures. For TriClip, we have been able to provide these angles to Paul and reduce the procedure time, fuse that with also the fluoroscopic angle, and been able to reduce substantially. This is pre, you can see this strain gastrous view and complete coaptation in the two clips and reduction of tricuspid regurgitation. CT can also allow for particularly procedures that will be tackling the tricuspid annulus, the relationship between the right coronary artery and the tricuspid annulus, the IVC dimensions. And also this global illumination software will allow us to see in real time not only the morphology of the tricuspid valve, but also the physiology. You can see that as that tricuspid regurgitation comes into place, regurgitate flows into both the IVC, the SVC and the IVC. Importantly, not only doing this before, but tracking the follow-up after intervention. So this is a patient pre-TriClip, this is a patient after tricuspid clip, 3 clips as you can see it here, and we can see that after we have done this, there was an improvement of even within short-term 30-day follow-up of ejection fraction and reverse remodeling. So therefore, there might be a better method to be able to track that reliably, the adequacy and the response to therapy. Strain is something that also we are quite interested in. We can do this by CT. This does not require any extra acquisition. It's the same acquisition, we can do this post-processing. A different patient, that same patient that I showed to you that had the large infarct, we expect this ventricle not to respond so much because obviously there is scar. These are the 2 clips afterwards, and we can see that despite the scar and the reduction of the tricuspid regurgitation, even within 30 days, there was already reverse remodeling as well, which we can account for. So therefore, in conclusions, I think there's a lot that we're learning, not only from echo as well, but other modalities, that there is a series of pathoanatomical changes that start with the right atrium tricuspid annulus, circularization, atrial fibrillation, then right ventricular dilation, right ventricular dysfunction. The timing needs to definitely be shifted more leftwards and upstream. And I would argue that patients that would have tricuspid annular dilation, or if you don't have good visualization of the tricuspid regurgitation, go for a TE or go for a CT, trying to use more anatomical factors to base your decision. CMR is also changing. We can do quantification. And CT, as I shown to you, can be reliable for not only pre-procedural, but track responsive therapy. Thank you very much.